Hey everybody, today we're going to discuss Chapter 10, which is capillary puncture, equipment, principles, and procedures. Looking at the objectives, there are 7 objectives for this chapter. Number 1, define and use capillary puncture terminology. Identify capillary puncture equipment and list the order of draw for capillary specimens and describe the theory behind it. Number 2, describe capillary specimen composition. Identify differences between capillary, arterial, and venous specimen composition and reference values. Decide when capillary puncture is indicated and demonstrate knowledge of site selection criteria. Number 3, name tests that cannot be performed on capillary specimens and explain why. Number 4, describe how to collect capillary specimens from adults, infants, and children. Number 5, describe specimen collection procedures and explain the clinical significance of capillary blood gas, neonatal bilirubin, and newborn screening tests. Number 6, describe how to prepare both routine and thick blood smears. Give reasons why they are sometimes made at the collection site and identify tests performed on them. And lastly, number 7, discuss potential complications of capillary puncture. So we will start out discussing the equipment you need for capillary puncture. You will need a lancet or incision device. There are 2 types of devices that are used for capillary specimen collection: devices that puncture the skin and those that make an incision in the skin. Both are commonly referred to as lancets. Lancets are disposable. They are designed for one use only and have sterile blades or points. They are available in a range of lengths and depths to accommodate various specimen collection requirements. Selection depends on the age of the patient, collection site, and volume of specimen required, and the puncture or incision depth needed to collect an adequate specimen without injuring the bone. Some lancets are specifically designed for finger punctures. This shows you pictures of finger puncture lancets, and others are specifically designed for infant heel punctures, and those are shown here. Micro collection containers or microtubes. These are small plastic tubes used to collect tiny amounts of blood from the capillary puncture. Some of them come with narrow capillary tubes attached. They have color-coded bodies or stoppers and markings for a minimum and maximum fill levels. Micro collection containers also are called microtubes. They are small plastic tubes used to collect tiny amounts of blood from the capillary puncture. They are often referred to as bullets because of their size and shape. Some come fitted with narrow plastic capillary tubes to facilitate specimen collection. Others have an attached or removable scoop or funnel device to assist with the blood collection. Most of these have color-coded bodies or caps or stoppers that correspond to color coding of the ETS blood collection tubes. They are the same as what's in the blood collection tubes, and markings for minimum and maximum fill levels. They are typically measured in microliters, such as 250 microliters and 500 microliters. Microhematocrit tubes are disposable, narrow-bore plastic or plastic-clad glass capillary tubes that fill by capillary action, and they typically hold 50 to 75 microliters of blood. They are used primarily for manual hematocrits, also called packed cell volume determinations. The tubes come coated with ammonium or sodium heparin for collecting hematocrit tubes directly from a capillary puncture, or non-additive to be used when a hematocrit is prepared using blood from a lavender top EDTA tube. Heparin tubes typically have a red or green band on one end. Non-additive tubes have a blue band. Smaller microhematocrit tubes designed for use with special microcentrifuges, such as those available from StatSpin, require as little as 9 microliters of blood, and those are what are used on infants and children, like anemia screening programs. Capillary blood gas equipment. These collection tubes are long, thin, narrow bore capillary tubes. They're normally plastic for safety and are available in different sizes to accommodate volume requirements of various testing instruments. The most common tubes for capillary blood gas are 100 millimeters in length with a capacity of 100 microliters. The inside of the tube is coated with heparin, typically identified by a green band on the tube. Stirrers are inserted into the tube after the blood is collected to aid in mixing the anticoagulant. A magnet is used to mix the specimen after both ends of the tube have been sealed. The magnet typically has an opening in the center or side so that it can be slipped over the capillary tube and moved back and forth along the tube length, pulling the metal stirrer with it, and that mixes the anticoagulant with the blood. Plastic caps or closures are used to seal these tubes and maintain anaerobic conditions in the specimen. Glass microscopic slides are occasionally used to make blood films for the hematology department. Warming devices. Warming the site is important when performing heel punctures on newborns. Heel warming devices are commercially available. To avoid burning the patient, the devices provide a uniform temperature that does not exceed 42 degrees Celsius. A towel or diaper dampened with warm tap water can also be used to wrap a hand or foot before skin puncture if you don't have a heel warmer. This is just a picture of your capillary blood gas collection equipment. Capillary puncture risks. Although mostly minor, there are risks associated with capillary puncture. Some examples are bruising, hematomas, infection, puncture site calcification, and scarring. The composition of capillary specimens. They differ from venous specimens in that blood obtained by puncturing the capillary bed is a mixture of arterial, venous, and capillary blood, along with interstitial fluid, which is tissue fluid from the spaces between the cells, and intracellular fluid, which is fluid within the cells. Because arterial blood enters the capillaries under greater pressure than the venous pressure, capillary blood contains a higher portion of arterial blood than venous blood. Consequently, capillary blood more closely resembles arterial blood than venous blood in composition. This is especially true if the area has been warmed, because warming increases arterial flow into that area. Reference values. Because the composition of capillary blood differs from that of venous blood, the reference or normal values also differ. Most differences are minor, though clinically significant differences in some analytes have been reported. For example, the concentration of glucose is normally higher in capillary blood specimens, while bilirubin, calcium, chloride, sodium, and total protein are significantly lower. Capillary hemoglobin and hematocrit values on 1-day-old newborns are known to be up to 12% higher than venous blood. Potassium levels may be falsely elevated if there is tissue fluid contamination or hemolysis of the specimen. Indications for capillary puncture. A properly collected capillary specimen can be a practical alternative to venipuncture when only a small amount of blood is needed for testing. Older children and adults, capillary puncture can be an appropriate choice under the following circumstances. Their available veins are fragile, difficult to assess, or must be saved for other procedures such as chemotherapy. Several unsuccessful venipunctures have been performed and the requested test can be collected by capillary puncture, then that's acceptable. The patient has burns or scars at sites commonly used for the venipuncture. The patient has thrombotic or clot-forming tendencies. The patient is apprehensive or has an intense fear of needles and capillary collection is acceptable. The patient is extremely overweight and veins are difficult to find. There are no accessible veins. For example, the patient has IV lines in both arms or only acceptable sites are in scarred or burned areas. And lastly, blood is being obtained for point-of-care testing procedures such as glucose monitoring. This is like done at the bedside and you only need like a drop of blood, then that's acceptable. Infants and young children. Capillary puncture is the preferred method of collecting blood from infants and very young children for the following reasons. Infants have a small blood volume, so removing quantities of blood typical of venipuncture or arterial puncture can lead them to have anemia. Large quantities removed rapidly can cause cardiac arrest. Life may be threatened if more than 10% of a patient's blood volume is removed at once or over a very short period of time. Obtaining blood from infants and children by venipuncture is difficult and may damage veins and surrounding tissues. Puncturing deep veins can result in hemorrhage, venous thrombosis, infection, and gangrene. An infant or child can be injured by the restraining method used while performing a venipuncture. And lastly, capillary blood is the preferred specimen for some tests, such as newborn screening test. Tests that cannot be collected by capillary puncture. Most tests today can be done on very small quantities of blood. However, there are some that are not acceptable. These include most erythrocyte sedimentation rate methods, which are called ESRs, coagulation studies that require plasma specimens, blood cultures, and tests that require large volumes of serum or plasma. Although light blue microtubes are available from some manufacturers, they are not to be used for capillary blood specimens. They are intended to be used for venous blood collected by a syringe in a difficult draw situation. So even though that blue top may be very small, keep in mind it is not for capillary puncture. It is going to be for a syringe puncture, but a small amount. So there are no blue tops that are done with capillary puncture. Order of draw. The order of draw for capillary is not the same as for venipuncture. Make sure you document this. Puncturing the skin releases tissue thromboplastin, which activates the coagulation process in the blood drops. Specimens must be collected quickly to minimize the effects of platelet clumping and microclot formation, and to ensure that an adequate amount of specimen is collected before the site stops bleeding. Specimens that are most affected by clotting must be collected first. The order of draw recommended by CLSI for capillary does take clotting into consideration. So first, blood gas specimens to minimize exposure to air, and usually they're collected totally separately. EDTA specimens because any clotting is unacceptable in a purple top. Any other additive specimens, because those are also affected by clotting. And then serum specimens are last because they are supposed to clot. Potassium levels may be falsely elevated if there is tissue fluid contamination or hemolysis of the specimen. Specimens for newborn screening should be collected separately and from a separate puncture site. Capillary puncture steps. Number 1, receive, review, and accession the test request. Number 2, approach, greet, and identify the patient. Number 3, explain the procedure and obtain consent. Number 4, verify collection requirements and identify sensitivities and potential problems. Number 5, sanitize your hands and put on gloves. Number 6, position the patient. Position is important to patient comfort and the success of this specimen collection. For finger punctures, an older child or adult patient should be lying down or seated in a reclining chair, blood collection chair, or other chair with safety features such as armrests to provide support and prevent falls. A young child is typically held in the lap by a parent, guardian, or assistant who restrains the child with one arm and holds the child's arm steady with the other while supporting the child's wrist. The person holding the child can also cross their legs over the child's legs to prevent the child from kicking. Ask the patient which hand to use and select the non-dominant hand, if possible. If the patient does not have a preference, always select that patient's non-dominant hand. Position the patient's arm so that it is slanted downward to encourage blood flow to the hand and supported on a firm surface with the hand extended and palm up. For heel punctures, an infant should be lying face up with the foot lower than the torso so the force of gravity can assist blood flow. Coordinate any needed changes to a bassinet, incubator, or phototherapy lights for infants in the neonatal intensive care unit or the nursery. Make sure you ask the baby's nurse so everything is returned back to the way it was prior to specimen collection. When performing a heel puncture on an outpatient infant, some phlebotomists let a willing parent hold the child during the procedure. The parent holds the infant upright over the left side and shoulder so the child is comforted by the parent's heartbeat. This position also lets gravity assist blood flow to the dangling foot. When you are sticking a toddler's hand, hold 3 or 4 of a toddler's fingers together. Number 7, select the puncture site. General site selection criteria include selecting a site that is warm, normal color, and free of scars, bruises, or rashes. It should not be cyanotic, which is bluish in color, usually from a shortage of oxygen in the blood. It should not be edematous, which means it is swollen with fluid, infected, or a recent previous puncture site. Accumulated tissue fluid from swollen or previous punctured sites can contaminate the specimen and negatively affect the results. Puncturing such sites can also spread undetected infection. Adults and older children. The site for capillary puncture on them older than 1 year is the palmar surface of the distal segment of the middle or ring finger of the non-dominant hand. Fingers on the non-dominant hand are typically less calloused. The puncture site should be in the central fleshy portion of the finger, slightly to the side of the center and perpendicular to the grooves in the spiral pattern of the fingerprints. Finger puncture precautions are summarized on Table 10.3 in your book on page 361. Infant finger puncture. Traditionally, finger punctures have been prohibited on infants younger than 1 year of age. However, some manufacturers have developed lancets that penetrate 1 millimeter or less. These are specifically designed for finger punctures on infants between 6 months and 1 year of age, provided that the infant weighs more than 10 kilograms. You must follow facility policy and lancet recommendations before attempting a finger puncture on an infant younger than 1 year of age. Finger punctures must not be performed on newborns because the distance from the skin surface to the bone, even in the thickest portion of the last segment of each finger, varies from 1.2 to 2.2 millimeters, which means the bone could be easily injured. Heel punctures or heel sticks are recommended for the collection of capillary puncture specimens on infants less than 1 year of age. However, it is important to perform the puncture in an area of the heel where there is little risk of puncturing the bone. Puncture of the bone can cause painful osteomyelitis, which is inflammation of the bone marrow and adjacent bone, or even osteochondritis, which is inflammation of the bone and cartilage due to infection. Additional punctures must not be made through a current or previous puncture site because it can be painful. The safest area for heel puncture are the most medial and lateral portions of the plantar surface of the heel. The safe areas of the heel are defined as the area medial to an imaginary line extending from the middle of the big toe to the heel, and the area lateral to an imaginary line extending from between the fourth and the fifth toes to the heel. Punctures in other areas, like the back side of the heel, they risk bone, nerve, tendon, and cartilage injury, and those are to be avoided. This is a cross-section of full-term infants showing the lancet penetration depth to assess the capillary bed, and this is a picture of where it is acceptable to do a heel stick in a baby. See those sides on each left and right side in that fleshy part of their heel, but never get the very back of their heel due to that problem with hitting the bone. Then also look on the left side at the recommended site and direction of finger puncture. See, you're on the fleshy part, perpendicular to the fingerprints, but kind of over to the side. Step number 8. Warm the site if applicable, if you need to. Warming increases arterial blood flow up to 7 times and does not significantly alter routine analytes. Increased blood flow makes specimens easier and faster to obtain and reduces the tendency to compress or squeeze the site, which can contaminate the specimen with tissue fluid and hemolyze red blood cells. Step number 9, gather your supplies and equipment. If you gather them ahead of time, then this helps. Once you've got the procedure going, you already got everything right there beside you. Select collection devices according to the tests that have been ordered and place them within easy reach, along with several layers of gauze or gauze-type pads. Select a new sterile lancet according to the site selected, age of the patient, and the amount of blood to be collected. Step number 10, clean and air dry the site with an antiseptic before puncture so that skin flora do not infiltrate the puncture wound and cause infection. The antiseptic recommended for cleaning a capillary puncture is 70% isopropanol. Do not use povidone iodine to clean skin puncture sites because it does greatly interfere with some tests. Notably, uric acid, phosphorus, and potassium are affected by using iodine. After cleaning it, allow the site to air dry to ensure maximum antiseptic action and minimize the chance of alcohol contamination of the specimen. Residual alcohol, in addition to causing a stinging sensation, can also rapidly hemolyze red blood cells. Step number 11, prepare your equipment. While the site is drying, this helps save time. Open a sterile package of equipment immediately before use. This helps ensure that sterility of equipment is maintained. Prepare equipment in view of the patient or guardian to provide assurance that it is new and being handled aseptically. Verify lancet sterility by checking to see that packaging is intact before opening. Open the package or protective cover in an aseptic manner to maintain sterility, and do not allow the lancet to rest or brush against any non-sterile surface. If the lancet has a protective shield or locking feature that prevents accidental activation, remove or release it per the manufacturer's instructions. Step number 12, grasp the finger or the heel firmly. Use your non-dominant hand to grasp the finger or heel firmly to prevent sudden movement by the patient. Hold the lancet between the thumb and index fingers of your dominant hand. Hold the patient's finger or heel as follows. For finger sticks, grasp the patient's middle or ring finger between your non-dominant thumb and index finger. Hold it securely in case of sudden movement. For heel sticks, grasp the foot gently but firmly with your non-dominant hand. Encircle the heel by wrapping your index finger around the arch and your thumb around the bottom. Wrap the other fingers around the top of the foot. With very young children, it is usually best to grasp 3 or 4 of the child's fingers at a time between your fingers and thumb. If you grasp only one finger, the child may twist it trying to pull it away. Although you are holding more fingers, it's still easy to puncture the middle finger because it is normally the longest and sticks out the farthest. Step 13. Position the lancet, puncture the site, and discard the lancet. Place the lancet flat against the skin in an appropriate area. Use sufficient pressure to keep it in place without deeply compressing the skin. Pressing too hard can result in a puncture that is deeper than intended. Warn the patient or parent guardian of the impending puncture. Activate the release mechanism to trigger the puncture. Remove the device from the skin following puncture and immediately discard it in a sharps container. Some manufacturers of heel incision devices recommend puncturing the heel perpendicular to the length of the foot. This creates a gap puncture, so follow the device of the manufacturer's instructions. Step number 14, lower the finger or heel and gently apply pressure until a blood drop forms. Position the appendage downward, applying gentle pressure toward a heel puncture site or proximal to a finger puncture site to encourage blood flow. Hold an adult finger with your fingers on top and your thumb against the pad. Use your thumb to apply gentle pressure to the pad of the finger to encourage blood flow. Alternatively, you can hold your thumb on top and apply pressure to the pad with your index finger. Do not squeeze. It may take a few moments for blood flow to start. Hold pressure until a large drop of blood forms at the site. Double sticking is never acceptable. If blood does not flow or stops flowing at any time and cannot be restarted, a new puncture at a different site must be performed. Step number 15, wipe away the first drop of blood with a clean gauze pad. The first drop is typically contaminated with excess tissue fluid and may contain alcohol residue that can hemolyze the specimen or keep the blood from forming a well-rounded drop. In addition, there have been reports of alcohol contamination causing errors in blood glucose testing. However, some point-of-care testing instruments may allow use of the first drop. so follow the device manufacturer's instructions. Step number 16, fill and mix the tubes containers in the order of draw. Continue to position the site downward to enhance blood flow and continue to apply gentle, intermittent pressure until a second drop forms. Continue to apply that pressure as needed to ensure the free flow of blood required for accurate test results. Make certain that your gloved fingers do not touch the collection site. Do not squeeze. Use strong repetitive pressure or milk the site because hemolysis and tissue fluid contamination of the specimen can result. Step 17. Place gauze, apply pressure, and elevate the site. After collecting the specimens, apply pressure to the site with a clean gauze pad until bleeding stops. Keep the site elevated while applying pressure. Elevate an infant's foot above the body while pressure is applied. Step 18. Label the specimens, confirming labeling information, and prepare the specimens for transport. Right after they are collected, put the label on the tubes. Include the type and source of specimen according to the facility policy. Label before leaving the patient's side or before dismissing an outpatient. Also label in view of the patient, parent, or guardian and affix the labels directly to the micro collection containers. Verify labeling with the parent or the patient or the ID band. Microhematocrit tubes can be placed in a non-additive tube or an appropriately sized aliquot tube for transport with identifying information written on that transport tube. Follow any special handling required, such as cooling in crushed ice for ammonia, transportation at body temperature for cold agglutinins, or light protection for bilirubin samples. Step number 19, check the site and apply a bandage. Examine the site for 5 to 10 seconds to verify that bleeding has stopped. If bleeding persists beyond 5 minutes, notify the patient's physician or appropriate healthcare provider. If bleeding has stopped and the patient is an older child or adult, apply a bandage and advise the patient or parent guardian to keep the bandage in place for at least 15 minutes and then remove it. Do not apply bandages to infants and children under 2 years of age because they pose a choking hazard. In addition, bandage adhesives can stick to their paper-thin skin of newborns and tear it when the bandage is removed. Do not apply self-adhesive stretchable gauze because it can roll up and cause a tourniquet effect that cuts off blood flow. Step number 20. Discard used materials, thank the patient, parent, or guardian, and dismiss outpatients. Step number 21. Remove and discard your gloves and sanitize your hands. And step number 22. Transport the specimen to the lab promptly. Okay, in your textbook, I do want you to make sure and look at page 366, 367, 368, 369. Let me just say 366 all the way to 376. These are going to give you detailed procedure steps for doing a finger stick procedure, a heel stick, a capillary blood gas, and neonatal bilirubin. Make sure that you look over these step-by-step procedures in your textbook. Neonatal bilirubin collection. Neonates are commonly tested to detect and monitor increased bilirubin levels caused by overproduction or impaired excretion of bilirubin. Overproduction of bilirubin occurs from accelerated red blood cell hemolysis, associated with hemolytic disease of the newborn. Impaired bilirubin excretion often results from temporary abnormal liver function, commonly associated with premature infants. High levels of bilirubin result in jaundice, which is that yellow skin color. Some amount of jaundice in newborns is not unusual as the infant's liver begins to take over the job of breaking down bilirubin, a job that was performed by the mother's liver before birth. This type of jaundice occurs in as many as 60% of all newborns and is called physiological jaundice. It is not considered pathologic and generally resolves on its own without intervention as the liver matures. If the physiological jaundice is excessive or the cause is pathological, bilirubin can reach toxic levels in the blood. Because bilirubin can cross the blood-brain barrier in infants, toxic levels can cause permanent brain damage or even death. Brain dysfunction caused by toxic levels of bilirubin is called kernicterus. A transfusion may be needed if levels increase at a rate equal to or greater than 5 milligrams per deciliter per hour, or when levels exceed 18 milligrams per deciliter. However, bilirubin breaks down in the presence of light, so jaundiced infants can be placed under special lights to lower their bilirubin levels. This treatment is called phototherapy. Phototherapy lamps emit a light in the blue spectrum, and any damaging UV light is filtered out. They also have phototherapy blankets that break down bilirubin that they can also use. The phototherapy light must be turned off when you are collecting a bilirubin specimen to prevent it from breaking down bilirubin in the specimen as you are collecting it. Bilirubin specimens are normally collected by heel puncture. Proper collection procedure is crucial to the accuracy of the results. You want to collect the specimens quickly to minimize exposure to light and protect them from light when you are transporting them to the lab. To reduce light exposure, collect the specimens in amber-colored micro collection containers. You want to avoid hemolysis, which could falsely decrease the bilirubin results. Bilirubin levels can now be assessed using a portable, non-invasive transcutaneous bilirubin measurement device. This point-of-care device directs light into the skin on the infant's head or sternum and measures the intensity of specific wavelengths that are reflected back to determine the bilirubin concentration. This device allows the risk of hyperbilirubinemia to be assessed quickly and easily with no pain to that infant. So that is a new way that they can test for the baby's bilirubin without doing a heel stick. Newborn screening. This is state mandated testing of newborns. It identifies rare but serious health conditions that can be present at birth, even though affected infants may not show symptoms of them at first. Positive tests require further testing. Current newborn screening has 3 parts. There is a blood spot screening, pulse oximetry, and a hearing test. The blood spot screening test check for rare but serious genetic, inherited, metabolic, hormonal, and functional disorders or conditions that can cause severe mental handicaps or other serious problems if not detected and treated early. Some states also screen for infectious agents such as toxoplasma and HIV. The number and type of tests vary by state. Requirements for disorders to be part of a state's newborn screening panel include funding sources for screening, benefits to early diagnosis, availability of accurate tests to confirm diagnosis, availability of treatments, and the incidence of the disorder in the state. Timing is when the infant is between 24 and 72 hours old. And common tests that are done in all 50 states test for fetal ketonuria, hypothyroidism, and cystic fibrosis. PKU, or fetal ketonuria. This is required by law in all 50 states. PKU is a genetic disorder characterized by a defect in the enzyme that breaks down the amino acid phenylalanine. There is no cure, but it can be treated with a special diet. Hypothyroidism. This is a disorder that is characterized by insufficient levels of thyroid hormones. It also detects non-inherited forms. Positive results are confirmed by a thyroid stimulating hormone test, and you treat this in the baby by supplying the missing hormone. Galactosemia is an inherited disorder characterized by lack of the enzyme needed to convert the milk sugar galactose into glucose needed by the body for energy. Within a week of birth, an infant with galactosemia will fail to thrive, and as a result of anorexia, diarrhea, and vomiting, unless galactose and lactose are removed from their diet. So you treat it by removing all milk products. Cystic fibrosis is a genetic disorder caused by one or more mutations in the gene that directs the protein responsible for regulating the transport of chloride across cell membranes. Cystic fibrosis involves multiple organs but primarily affects the lungs and the pancreas. The mutation causes the body to produce thick, sticky mucus secretions that build up in the lungs and other organs. The mucus obstructs passageways in the lungs, leading to pulmonary infections. Early diagnosis and treatment helps avoid respiratory distress and malnutrition and has the potential to increase life expectancy. Blood spot collection. The blood spot tests are performed on a few drops of blood obtained by heel puncture. The blood drops are collected by absorption onto circles printed on a special type of filter paper that is normally part of the newborn screening form. The blood-filled circles are often referred to as blood spots. Currently, as many as 80 different disorders can be detected in the blood spots on one form. Each circle must be completely filled with one large free-flowing drop of blood applied to one side of the filter paper without touching the filter paper to the surface of the heel. The drop should soak through the circle and completely fill the other side. The same process is continued with subsequent circles until all the circles are filled. Unfilled or incompletely filled circles can result in the inability to perform all the required tests. Circles must be filled from one side of the paper only and by one large drop that spreads throughout the circle. Application of multiple drops or filling circles from both sides of the paper causes layering of blood and possible misinterpretation of results because the spot will contain more blood than normal. After collection, the specimen must be allowed to air dry in an elevated horizontal position away from heat or sunlight. Specimens must not be hung to dry or stacked together before, during, or after the drying process. Hanging may cause the blood to migrate and concentrate toward the low end of the filter paper and lead to erroneous test results on the sample. Stacking can result in cross-contamination. When dry, the requisition containing the sample is normally placed in a special envelope and sent to a state public health lab or other approved lab for testing. Results are sent to the infant's physician. Routine blood smear. This is a picture of what has happened this is required sometimes to perform a manual differential, which is a test where the number, type, and characteristics of blood cells are determined by examining a stained blood smear under a microscope. 2 smears are normally prepared and submitted for testing. I want you to look at page 383 and 384, and 385. Those 3 pages in your book is procedure 10.5. This gives you the steps when you perform a capillary puncture to be able to do a blood smear from a capillary puncture. You can do thick and thin smears, but if you do a thick smear, you do need to know what those are for. They are used to test for malaria, diagnosed by the presence of an organism in the peripheral blood smear. A very large drop of blood is placed in the center of a glass slide. The drop is spread with the corner of another slide or the cover slip until it is the size of a dime. You allow it to dry for a minimum of 2 hours. You stain it, and then in the lab they will look for the organism that causes malaria. This finishes up our chapter on capillary puncture. These are the NACLS competencies that we discussed throughout the chapter. As always, let me know if you have any questions, and I will talk to you next time.